Today I'll be presenting my idea of how one technology could help better the future in medicine, and that is Dr. Wear. So I want to start off by asking my audience, and I guess if anyone's watching the video, take a wild guess of how much of the population of Alberta is actually living in a rural area. Have any guesses?
A lot.
Yeah.
Yeah, hundreds of thousands of people.
Yeah. So yeah, we're looking at about 750,000 people of Albertans living in like rural or remote areas, and this isn't including the number of people that are living in rural centers like Grand Prairie or Fort McMurray, which still have hospitals, but they're still unable to care for certain major acute diseases like heart attacks or strokes. Those can be stabilized there, but ultimately they're medevaced to either Edmonton or Calgary for full treatment. So that's one of the problems that hopefully in the future a technology like this could address, is the access to healthcare in a rural setting. On top of that, it's difficult to reach major care centers from remote locations, especially in both non-critical and critical situations. If someone has to drive from, say, a reserve far out in northern rural Alberta to Edmonton, that could take half a day or a day of driving, even to a rural center like Grand Prairie. Another thing that plagues our healthcare system is wait times and physician availability. Telemedicine has been proposed as a potential solution to some of these issues, but you can only do so much through a video or a phone call. You still can't do a physical examination of the patient, and you're subject to their ability to describe what they're feeling, which can be difficult to interpret at times. In terms of wearable technology today, there's still some gaps in their performance, like there's concerns in their measurement accuracy, and also the mechanisms for determining certain conditions are proprietary and little known because they're considered trade secrets by these companies. So what's the goal? Is to provide everyone, beginning with Albertan residents, with access to proactive health monitoring, with the goal of increasing overall population health, which would hopefully over time decrease the strain on overburdened healthcare resources. And so this system would initially work with the most popular wearable devices and provide accurate health insights to physicians regarding cardiovascular, sleep, health, some aspects of psychological health, and metabolic health as well. But there are some key fundamentals to this solution, and that would be that A, we'd have to address regulation that comes around it, and this I'm sure is only addressing like a tip of the iceberg of the regulation roadblocks that would be faced by this idea, and that is to have local processing and storage of information. As you'll see later on, each province has their own acts on how to deal with patient information, and so in terms of where the service is provided, that's where the data centers holding the AI models and the data of the patients are located. This would be physician powered. Physicians are still the ones monitoring the data and ultimately holding responsibility for the patients. It would be ideally tailored for everyone, so as many devices would be supported as possible and personalized to everyone's needs and lifestyles. And it would also be not for profit because we want to ensure that the patient's best interests at heart, and that sometimes may not happen when you have a company that has profits as their number one interest. So how would this system work? We would have we'd have a collection of data which involves potentially years, even decades now since wearables have introduced, of wearable data being stored in the same place as data from your electronic medical record, which can include things like lab work and imaging. And this would get fed to a series of AI models and systems that would then generate predictions of your trajectory of health, whether you're on a concerning path to developing some sort of preventable chronic disease, or that you're doing a good job. The physician then reads these and determines whether they hold weight. It can also converse with the system to get more information, and if it deems that the insights are correct, either tell the patient, you're doing a great job, keep it up, or we need to schedule either like a remote or in-person consultation to see what we can do to fix your current trajectory. So just to reemphasize, what are the roles of the physician, the patient, and the AI in this proposed system? Currently, at least, pre-singularity. We'd have the physician, which is responsible for patient care and interaction. They would communicate with the patient as needed and prescribe the treatments. The patient would just be responsible for wearing the device regularly, and they can access healthcare resources whether remotely or in person as needed. And then the AI would be responsible for crunching lots of data. It would be unreasonable to ask a physician go through 10 years of smartwatch data to determine how the patient has lived up until this point and then how they're going forwards. And so they continuously analyze these lifestyle patterns, ideally discern between inaccuracies in device measurements and legitimate ones, and then create predictions for the health trajectory of the patient. I got here like an AI-generated image of currently kind of what we're able to see from wearables, and that includes things like cardiovascular health and fitness, where wearables are even able to detect atrial fibrillation or hypertension, for example. They monitor sleep health, so sleep duration, sleep SpO2, so blood oxygen. They can even look at some limited aspects of metabolic health and psychological health as well. Initially, this system would support the most popular devices, but in the long term, in the future, we look at making our own devices which could be actually accessible to the general population. Some futuristic capabilities of the system, perhaps it could infer your emotional state at the time. It could look at blood sugar levels without having to have a patch that is stuck to you for 2 weeks at a time. Maybe currently, if you want to initiate an ECG or a blood pressure measurement, you have to do it yourself. You have to hold your finger on your watch. What if you could do that without the need of any intervention and basically be like a Holter monitor or an ambulatory blood pressure monitor? What if it could even predict a heart attack? That could help prevent a lot of serious issues in patients. It could also potentially be used to determine the predisposition of patients to multifaceted diseases or even hereditary diseases as time progresses and more interest is dedicated to genomics. Now, there are a bunch of issues with wearables at the moment. One big thing that we kind of touched on briefly was they refuse to take responsibility for the insights of their devices. Whenever you get any sort of notification, like for example, an irregular heart rhythm, they say consult with your physician. Now, that notification could just be triggered from an inaccuracy in measurement. Let's say you moved your finger a little bit and the ECG looks very wonky, and so the watch might think there's an issue with you when actually it just didn't measure it properly. And now it can now take further time out of the consultation between the physician and the patient for the physician to determine whether it's a legitimate concern and also to discuss that with the patient. They provide analyses of their measured metrics, but again, they don't really tell you how they're analyzing these data. And the data is handled according to the company's privacy policies, which likely are much less stringent than what we see in our Health Information Act in Alberta. They're also for-profit, and they can be a nuisance, as we discussed previously in the course. Sorry, that's the typo. But essentially, compared to current smartwatches, this system would be monitored by a physician tasked with helping you live healthy. Data would be stored in the jurisdiction of health and linked to your EMR chart. It would be not-for-profit and tailored to each patient. So one big issue that was raised when I previously presented a glimpse at this idea was that wearables can be quite annoying when you're doing daily activities. These are some AI-generated images. For example, you could just be doing tuck jumps or working out, and then it thinks you've fallen. So now your emergency contacts are getting notified when you're perfectly fine. You could be in the middle of a meeting or driving, and it's telling you to go move even though you can't at that moment. Or you could have actually fallen, and the fall detection feature fails to initiate, and so you might be in need of help, but it's not doing anything. In this solution, you'd have something where You're complimented for adapting. So, for example, let's say you have a day of work, but you managed to get your workouts in before. It'll tell you, you hit your start goal earlier, good job, and it won't bug you to keep moving throughout the day. Or it can detect that you've been driving, so it'll say, enjoy the road trip, make sure you take stretching breaks. Or it can see that your previous pattern had an unhealthy diet, but over time it sees that you've been improving it. It'll tell you your metabolic health has improved. Keep up the good work. Now, as for these in-house devices that could be made, we could have something that is as simple looking as a watch, but actually still has the same sensors that are packed in wearables today, so that it's not a distraction to you, you're not connected to your cell phone all the time, but it can still detect when you have a fall and show you that, or it'll still be monitoring you just like a normal wearable does. Or you could have a smartwatch that has a screen that is invisible to others, but then to you, you can see exactly what's going on, a more futuristic version. And so, just to make sure I have it down, the design of this system would be friendly, comprehensive, accessible to ideally everyone. Your data would be private, it would complement physicians, and it would be non-invasive, potentially even easier than wearing a watch. Currently, AI has been implemented into healthcare, where we can see that in image analyses, in radiology, for example, it has been shown to help improve the detection rate of breast cancers in mammograms. You can have it be used to classify cancer cells in healthy tissue, and even in dermatology, where skin lesions can be classified. Currently, though, in the case of family physicians, which would be responsible for monitoring the system, AI has a limited scope where it can be used as a scribe, but that's typically the extent that we see it being used in family practice. When it comes to live analysis, it can interpret ECGs like we mentioned, albeit for a limited number of cases, in this case AFib, and it can provide you a score that essentially dictates how capable you are to do certain activities for the day. Let's say if you have a higher score, you can go run a 5K or do a workout, but then if it says you have a lower score, you might want to take it easy that day, get to sleep early. But now, getting into some regulation blocks in the future, so we have to keep in mind the privacy and the security of the information of the patient. And so there are multiple acts that, depending on what the solution is, your solution can be susceptible to. Dr. Ware, in this case, would fall under Health Information Act, which is the Alberta's legislation for health information. And how we would comply with that is the patient would have the ability to withdraw their involvement of all of their data, and anything that identifies the patient, that data would be removed. Patient access to the data would be possible and easy to do. Patients would be notified in the unlikely event of a data breach, and physician access is law. Additionally, information would have to be secured. So from the wearable all the way to the physician monitoring it, everything would be encrypted to ensure that this information is kept safe. Now, just expanding a little bit on the regulation, what does the Health Information Act actually dictate? Here are some of the rights of each patient. You can access a copy of your health information, request any corrections or amendments, protect your health information and understand how it's being used, collected, and disclosed to other parties. Know why it is being collected, express any wishes or concerns regarding your information, and request an independent review. Now, all of those above are managed by a custodian, which in this case would be your physician or AHS, depending on who's holding it. But now, let's get into some future questions and ethical concerns that we could have about AI in medicine in general, and also how they could apply to Dr. Ware. For example, some people may have the concern of surveillance. This could be seen as the government finding a way to invasively track citizens. Since healthcare is public in Alberta and Canada, there could even be potentially tax brackets could be influenced based on lifestyle patterns. If an individual has been seen to engage in risky lifestyle patterns or an unhealthy lifestyle, it would be expected that they bear a higher cost to the system. And so that would be the rationale for that. Private corporations, on the other hand, could now have access to not just your consumer DNA, but also your health information, which could then be sold, or health insurance could skyrocket in price. Patients could also be targeted with supplements or pharmaceuticals based on what they can see. There can also be over-reliance on these systems, so the patient could be stressed from the constant monitoring of their every move, and could also, since this system would initially rely on just the devices that are available, they could rely on the insights from these devices more than the guidance of the physician. On the other hand, the physician could trust the data too much and not really scrutinize any discrepancies. The autonomy of the patient could also be violated because their lifestyle becomes an open book to the physician. They're no longer in control of what they disclose and what they don't regarding to the physician. The physician is also relying more on these insights, so that could lead to a future where the physician would make less original discoveries and decisions. For example, they wouldn't likely not actually find the disease, but rather change to a mentality where AI found this, let me make sure it's right. And also inequality could occur, especially if this would be owned by a private company who can access such programs. If the devices are very expensive, probably not every Albertan or person could use these. Additionally, if they're living in a remote area, I'm just assuming the ideal circumstances that they have internet access, but they may not. So how would that information get to the processing center and also to the physician? And so looking at post-singularity, I think what the privacy is also who owns and uses the AI companies. If the physician is still using and employing the system, the HIA would still apply as they're the ultimate custodian. But if the physician isn't part of this, if it's like a company to physician approach, then the federal legislation would apply. But we also have to look at, would privacy have to be relaxed in the future in order to drive innovation of AI? Like I've talked to a professor who's told me that it's very difficult to actually get access to even anonymized patient data to then train AI classifiers on to improve their capabilities. In the future, would something like this have to be relaxed, so where anonymization is enough in order to improve AI models? And also during the singularity, if AI is used to dictate policy in the far, far future, if it's being used to lead us, will AI be regulating its own use? And so another consideration is who's caring for the patient, AI or the physician? In the current case, AI would just predict the health trajectory over time, and the physician would be relied upon. And again, the physician is the one vetting all this and communicating with the patient and responsible for providing care. But what if the AI becomes smarter than the physician, for example, in the singularity? Does the AI join the conversation for the best treatment, or does the AI unilaterally decide the best treatment? Who regulates it in this case? And so, yeah, to summarize that, pre-singularity, the physician is responsible, but post-singularity, the AI could become the provider for the patient. But then in that case, that also raises questions like, if AI messes up, it makes a bad judgment call, and so the patient's health deteriorates rapidly. How do we punish AI, or how do you accuse it of malpractice in that case? And what is the physician's new role? What is the human brain's new role in this case where AI would be responsible during and post-singularity? And so I guess some future pathways that we could look at the singularity in healthcare is a utopian future where you have large teams of the smartest physicians partnered with AI to deliver medicine to a superhuman level of accuracy. And so physicians could handle more patients than ever before, and detect diseases and treat them with much better accuracy than before. You could have a dystopian future where AI takes over unilaterally, handles everything, and the human touch is lost. Or a more realistic approach that I see in the future is a more tame version of the utopia, where AI could handle the analysis of routine checkups, speeds up analysis of lab works and imaging. AI could devise potential treatment pathways, and then ultimately physicians and patients have the final say. Now, circling back to the solution, what could be some intended and unintended consequences of doctor wear? You could have, ideally, it lowers the burden on healthcare resources by lessening the amount of frequent in-person checkups and overall improving population health. Unintended consequences, though, could be the over-reliance on remote healthcare. If the system is poor in quality, you could have excess time spent by physicians reanalyzing data, and you could even have competition between friends, family, who can be the healthiest, which could actually ultimately lead to an unhealthy lifestyle. And you could also have people who find clever ways to fake measurements, and so it will look like they're improving their lifestyle, when actually nothing has changed. Ideally, this would start here and then move on to the rest of Canada, and potentially, if it's a good solution, even global. And just one last thing before finishing up. I also mentioned, what if it could be even easier than wearing a watch to have your vitals monitored and your lifestyle monitored? And that would be something like a smart skin, where it could be as thin as a temporary tattoo. Could detect everything that current wearables can, so your heart rate, for example. And even more, potentially with the use of other membranes on top, you could even have the detection of blood sugar. And you wouldn't need to charge it. It would last about a week. And it would be another solution that is less invasive than even wearing a watch. Thanks for your attention.
Okay, great. So I think there are like two ways to look at these kinds of consideration. One is that the regulations of medicine would never allow this, like it wouldn't be approved, and so your physician wouldn't be allowed to spend any time using the data from this because it's not an approved device, and yeah. But because the world out there of AI and quantum and so on is moving much faster than governments and medicine, regulations and rules are going to change, but that's maybe the hardest thing to predict, because there's lots of idiosyncratic aspects of when you change a law or whatever, and how you do it, how different countries are. Is there going to be tourism? Maybe if your device becomes really popular, but is only available in Canada, people will travel here, you know. So it's hard for the entrepreneur right now to figure out what's going to be financially successful. You know, I think taking a course and presenting it in the course is the kind of low risk thing. You don't have to, like, you know, invest a lot of money. But if you were trying to make a living in a for-profit company doing this, it would really be hard to figure out what's the likelihood of success, and, you know, even what country to try it in, you know. So it's intriguing. So how close are you to actually, like, you're accepted into medical school? Are you gonna spend all the time between now and the time that medical school begins actually building this thing, or no?
No. I'm involved in research. This was just like an idea.
Yeah, right, yeah. So it's like the rest of this course. It's speculative, it doesn't exist yet, and you're working on it is also speculative. That doesn't exist yet. You're not like spending hours a day making this into a reality. But what do you guys think? I mean, don't you feel that a lot of the rigidity that we currently encounter, like using Epic and so on, is bound to change, but you just don't know who's going to get to make the change or how people will, decide that. And yeah, so if somebody comes up with an app like this that is actually better than anything we're currently using, then we would probably ultimately incorporate it into the medical system. But the barriers to doing so, in theory, are like enormous.
Yeah.
So some of those barriers would fall away somehow as time goes on.
So I have some questions that I think will help tell you what how I feel about incorporating this. But so first, I want to say that I think that was a really good presentation. Like I think that you touched on really important concepts when you're looking at something like this, where you have constant monitoring, things like overdiagnosis, things like accountability for the data. Those are all things that I would have asked you about. Well, I will still ask you about, but I would have asked you about that you touched on, which is really good. So my first question is a very simple one. You're going to build data centers to store all this data. How long are you going to keep the data for? Because 24-hour data monitoring, capturing ECG tracings, blood pressure if you can, blood sugar, that's a lot. 24 hours a day for every person in the province is going to be an enormous amount of data. So where's your cutoff? Like, are you going to keep it, or you think you're going to keep it for a month unless there's something, or is this going to be 5 years? Which city are you going to buy up to build the data center on top of?
I think currently there is Albertan legislation, I think it's the Hospitals Act, where something like, I think it's up to 10 years that data has to be stored for a patient. So we'd probably fall under the same legislation, but again, you do represent a big issue there. So I actually tried it for myself. I've been wearing like a smartwatch for nearly 10 years now, and I tried to download all the data. And it's mostly consistent wearing, and I think it came out to a couple megabytes, maybe, total.
Megabytes?
Yeah, so not a lot, actually. The way they store it is pretty efficient. And so, yeah, it would take like probably a city or two, and then that would have a considerable impact on their water supply, their electricity, even just traffic. If it's a rural city, all of a sudden you have like huge construction. So that would be a big impact, and that has to be considered. Also powering these things, I think like even AI in general uses a lot of energy models. And so there would have to be a sustainable way to power them. Ideally, clean electricity, which I think would be even harder to convince the government on currently, because that would be one sustainable method to keep a data center up while hopefully minimizing the environmental impact. Another mitigation would have to be that ideally this would be built in an area where there's already plains. We wouldn't want to sacrifice the forest area as well.
I mean, the data centers are being built, right? Kevin O'Leary just announced a couple months ago with Daniel Smith that he's going to build like a $700 billion data center in Grand Prairie just for AI. And I think it's the biggest one in the world. And in terms of energy consumption, China is moving incredibly fast towards nuclear fusion technology and using that to power their electrical needs. And the U.S. is moving towards that. I think Trump signed a bill recently about passing for more nuclear plants in the U.S. To kind of catch up to what the China is doing in terms of production of energy. So I think we're all moving in that direction. I'm surprised to hear that it's only megabytes for 10 years of data.
Yeah.
So maybe more efficient storage could be could be an option.
Because it's just like they're big, think about them like big Excel files with just a number of cells. So it's not like you're storing images or something like that.
But,
It's just-
that's the problem, is that if you're talking about taking this from the data collected on a watch to then be reviewed by a physician.
Yeah.
So like, if you provided me with an Excel sheet with a bunch of digits, I can't
Yeah.
do anything about that.
Yeah,
So
exactly.
the data that's collected is not usable data in a clinical setting. So to collect usable data, like over a 10-year period for an individual, you're talking about like multiple terabytes, if not whatever the next 1,000th up is.
Yeah.
Because you need to look at the tracing, you have to look at the blood pressure trends, look at the heart rate. Like, there are things that you need a bit more data on. But it's not something you can answer right now. I think what Jimmy talked about of like more efficient data storage, and I don't know, you can zip folders to compress things down and re-expand them if you need them. So
Actually, if you just hold that thought, I just have like potential visual of how that would work. So let's say here we have like let's say we have a potential patient here, Robert Thompson. And the way how I would see their data being visualized, like their wearables, is you could see the things that are measured by wearables, and you can click on each one of them and see trends over time. But yeah, what you're saying is right. All of this will take up a lot of storage.
my second question kind of touches on two things. One is accountability, and one is overdiagnosis. So under the model you proposed, the physician is ultimately accountable. So in a clinical setting, if I get called about a hypotensive patient, right, in the hospital somewhere, my responsibility is I have to go to the patient's chart, I have to look through their previous blood pressure, right? Like when you get called about a patient whose blood pressure is 80 on 50, it's very different if their last blood pressure was 150 on 100 versus if the last one was 85 on 55. So you have to look back, see what the trend has been. You have to see why the patient's here, you have to examine the patient. So you have to collect a lot of information before you can make sense of what a single blood pressure reading was. The problem you run into with accountability, so I'm accountable for that, right? So if I get called about that, I don't look at that information and I make a decision and it's the wrong decision, I'm accountable because I missed a piece of the data. If I'm, let's say, a family physician somewhere, and I get a notification, patient's heart rate is 105. If I'm going to be accountable for it, then I have to start going back through data. And we're talking about not measurements taken every 4 hours by a nurse, we're talking about 24 hours of data. So then you're going back, so then where's the cutoff? If I'm accountable, if I only go back 24 hours, but 25 hours ago there was something significant, am I accountable for that? If it's a month ago, am I accountable? And I think that's where you'd have trouble signing people up to be accountable for this, if you're now accountable for this unlimited amount of information that you could really never process yourself, making a decision. The second thing is overdiagnosis, which I think fits in all of this information. So you already touched on it, so I think you kind of have an idea of the concept, but we restrict the testing that we do intentionally. One of the reasons is because of overdiagnosis. So we don't send a troponin for every patient that walks in through the emergency room, because then your consults for cardiology, your number of CATs are gonna go up, and a lot of it's gonna be things that are, just incidental findings. And so I envision the same thing here, is that now your family physician is getting bombarded with heart rates of 105, irregular heart rate for 10 seconds. Again, the AI can maybe parse out some of what is real and what's not, but overdiagnosis would be a big issue with collecting data 24/7. So even for us now, if I get a troponin that's elevated, my hands are tied, right? I can't discharge the patient home without following up and doing more investigations. So those two things, so how would you reconcile those two things? How do you pitch it to a family practice of 10 doctors where you say, I want to sign you on to this and get you involved with this program?
I have to give it some more thought, honestly.
That's a long-winded question. That's a lot of information, but
yeah.
Yeah, there's also the keeping up with the Joneses thing, right? If this really takes off worldwide, then it's easy to sell it locally here because people are already doing it in the US, and Sweden, and so
I kind of have an idea about the answer, so I can give you a hint, but I
Sure.
just wanna get your thoughts about it, having already gone through all of this stuff.
Yeah, I mean, I guess you have a point, and I don't know how I would mitigate it, because ideally, the exact same metrics are provided for every patient. And you're right, what if you scan to an extent, like, so here, technically, these graphs go back a year. What if something happened a year and a month ago, just like you said? And so that would be difficult to detect by the patient, and ultimately, you'd be relying on the system to tell you about it. But then, of course, there's a question of, what if the system misses something? Why should the physician be held accountable for that, I guess? So you have a point, and I'm not exactly sure how to reconcile it in this case where the same measurements are provided for each patient, which goes against what you're saying, which is where you don't order every test for each patient because that would overburden resources and also incidental harm.
Yeah. My pitch would be that there has to be like a balance in the accountability, like you have to, as a physician, do what's reasonable, right? So again, you could, if I had to go through this chart and look at every one of these parameters for a year, that would be my whole day to try to figure that out for one patient. So you have to, I think, as the physician, do what's reasonable, so you get a notification about atrial fibrillation. The system ideally would pick out what the atrial fibrillation segment was and show it to you.
Exactly.
And then you have to maybe look at some of these trends to see were they having periods where they're tachycardic or not and go back through those, but you don't have to scan every piece of information. The system should summarize for you. So if you go to our ward, like cardiac surgery ward, all of our patients are on telemetry. So when the nurse calls me and says a patient went into AFib, usually the nurse knows what time, right? But they'll tell you, okay, well the patient went into AFib an hour ago. So when I go in, the system has marked what the alarms were. So I don't have to look through the whole thing, I can just scroll through the alarms and see, okay, well they were in AFib for 5 beats or for an hour. And I can scroll through those very quickly, and it only takes me 30 seconds to look through a patient's last 24 hours of alarms, because it'll pick those things out for you. So it's unreasonable for somebody to come and say, you're responsible to look through every second of every tracing for the last 24 hours, but I should at least look through the alarms to see what the issues were. And then the accountability, it's, this is something that's additional, so it's preventative, so I think has to be some leniency in that things will be missed, like always, but this is, missing something here should not be held to the same standard as missing something in the hospital where you can examine the patient and see them. So the pitch to the patient is you may have something picked up that otherwise would be missed or that may be picked up later, but it doesn't mean that nothing will ever get missed. And for the physician, it's the same thing, is that, okay, well you might pick up something in your patient, doesn't mean that you're responsible for, your 3,000 patient practice to make sure that nothing ever happens to anybody outside of the clinic.
Right.
So it has to be a balance, and you have to pitch it as this is an additional screening thing.
Yep, for sure. And actually, sorry, I guess I forgot to mention it, but that was the initial idea, is when it shows you, let's see if I have it here. When it shows you something like, yeah, okay, look, they're heading towards hypertension, it shows you exactly where and where measured. The same thing if it picks up atrial fibrillation or sleep apnea. It'll show you, okay, we saw here there's rhythmic drops and it shows you a graph. That's the whole point, is that you don't have to go back and scan through. And yes, the whole idea is that it's preventative, so ideally we catch these conditions before they're getting to that point where the patient is not compelled to actually see their doctor because it's taking a huge impact on their life.
Yeah, so if I was going to summarize it, I would pitch this as a screening tool. So with screening clinically, what you want in something, the difference between sensitivity and specificity?
Yep.
In screening, sensitivity is more important than specificity. Obviously, you don't want to have a very low specificity because you get lots of false positives.
Yep.
But if you have a tool like this that's very sensitive, even if it's not the most specific, you can find things that would otherwise be missed. And then, once you implement this, what you do is you look at it. So how many times does a hypertension alarm go off? Does that correlate to new diagnoses of hypertension? How many false positives are there? If you can show that those numbers are reasonable, then you can convince. If you show that the sensitivity is high, the specificity is also reasonable, and that you're picking up on hypertension, diabetes that would have been missed, then it makes it very easy to recruit new physicians to start advocating for this to be used in their patients.
Yeah, and then I guess what you're bringing up here is also how would it get, like how would we get to the stage where we'd actually test it? And I think that would require like some sort of pilot rollouts where certain communities, it just kind of works in the background. The physician isn't using it, but it's just collecting data, and then afterwards, physician researchers would be able to evaluate it and see how many times it was actually accurate based on a real diagnosis done by the doctors as well for those patients.
But even a test where it is active, like if you take a community of 1,000 people, and you give them the watches, and you see, if there's 500 alarms for hypertension, does that correlate to 500 diagnoses of new hypertension, or
Yeah.
10?
Yeah.
And then, in that, it's not a failure of the system, but it just means you need to retrain it, right? That's the nice thing with this, it's flexible, so you can make it more conservative or less conservative in what alarms, and eventually you can tailor it to be where you want it to be, sensitive enough, specific enough, but not missing.
Exactly.
That's all my comments.
Okay, great. Yeah, do you have anything?
I do have just a quick question.
Yeah.
First of all, I thought that was a great presentation and really well thought out. The other point I just wanted to kind of ask about and expand on, you mentioned that this device is tracking the health behaviors of the patient, so in that way they're kind of an open book to their physician. I wonder if this technology was expanded to private healthcare systems where patients are relying on their insurance company or their insurance plan to cover their treatment. Ideally, you would want that health behavior information to stay confidential and to go to the physician only, but do you think insurance companies would sort of push against that and insist on accessing that information in any way? And how would you kind of stop that from happening?
Yeah, so I guess we can look at another case that I'm aware of, because I have friends that use this. Look at car insurance, where I think you can bring down, or unfortunately raise your quote, by letting them use your phone to monitor your driving patterns, and they can look at how fast you accelerate. If they know the speed limits of the roads, how fast you're driving, your braking, just your driving patterns overall. And that could be used to lower your quote, or it could even be raised because they could classify you as a high-risk driver. So unfortunately, in a private healthcare setting, it could actually lead to that, where you could have insurance companies lobbying for this data. And then, just like I mentioned, a consideration would be that health insurance could skyrocket if they see that your lifestyle is unhealthy, because they know you're going to be more likely to claim the insurance. Whereas if you're living healthy, they may just keep your premium the same, or they may discount it knowing they won't, or less likely to claim in the future. How to stop it? It would have to be probably like a lot of government regulation, but then again, you could have like always the insider. You could have people in the government who their spouse may hold positions in some insurance companies, and then it also creates a loophole in government regulation as well, potentially.
Okay, great job, thank you. So we'll meet again on Tuesday, and these two guys present. Very good, all right.